At number 2, Dr. Shatobhisha, then Dr. Shomik, Dr. Anu, Dr. Archita, Dr. Himadri, and Dr. Sudarshana. Dr. Swadha. Dr. Swadha, please take the stage. Please check your presentation. It's okay? So you'll have the timer. You can see the timer? Yes. Right? You have 5 minutes. Okay? After that, you will face questions. Shall we start Utsho? Utsho is our coordinator over here. Sir, ma'am, shall we start? Our judges, please. We are starting. Please go.
Good afternoon, everyone. My paper is titled as Clinical Pathological Study of Scleroderma in a Tertiary Hospital. Scleroderma is one of the autoimmune cutaneous connective tissue disease characterized by fibrosis and thickening of skin due to excessive collagen deposition. It has two groups. One is systemic scleroderma with visceral involvement and localized scleroderma, also known as morphea. Clinical subtypes of morphea include plaque form, linear, generalized, guttate, and bullous. Clinical variants of systemic scleroderma includes diffuse systemic scleroderma and limited cutaneous systemic scleroderma. The aim of my study is to correlate clinical presentation, histopathological features, and prevalence of localized and systemic scleroderma. It's a 3-year retrospective observational study from 1st January 2021 to 31st December 2023, including 33 cases which were diagnosed clinically and histopathologically as morphea or scleroderma. Data collection was per proforma, and clinical details were taken from the medical records department. This is my proforma. Coming to the results, 13 cases were systemic scleroderma and 20 cases were morphea. 9 cases were males and 24 were females. And morphea did not show any gender predominance. 12 cases were females and 8 were males. And systemic scleroderma had female predominance. 12 cases were females and 1 case were male. And morphea was more found in younger age groups, whereas systemic scleroderma was found more in older age groups. Morphea had associated pruritus. 6 cases were having associated pruritus. And associated comorbidities such as diabetes mellitus was found in 5 cases each of morphea and systemic scleroderma, and associated hypothyroidism was found in 4 cases of morphea and 6 cases of systemic scleroderma. Vitiligo, porphyria cutanea, and rheumatoid arthritis was seen in 1 case each of morphea, and Sjogren syndrome and SLE were associated with 1 case each of systemic scleroderma. Out of 10 patients for whom autoimmune serology was done, 4 cases were positive in morphea and 6 cases were ANA negative. And out of 12 cases for whom autoimmune serology was done, 11 cases had positive autoimmune serology and 1 was negative in systemic scleroderma. And systemic scleroderma was mostly multifocal, and morphea was both unifocal as well as multifocal. Hyperpigmented macules were more commonly associated with morphea, and depigmented and hypopigmented lesions with salt and pepper pigmentation, telangiectasias and digital ulcers were more seen in systemic scleroderma. Upper limb and face were the most common location of lesions in systemic scleroderma, and abdomen and back were the most common location of lesions in morphea. Coming to histological features, epidermal atrophy was seen in both the cases. Sparse and mild inflammation was more seen in systemic scleroderma, and periadnexal infiltrate and interstitial infiltration was more found in morphea, and subcutaneous involvement was seen in both the cases, and panniculitis was seen mostly in morphea, and loss of periactin fat was found in both the conditions. The histological diagnosis based on inflammation and degree of homogenization of collagen was done, and morphea was categorized as late and early morphea. 7 cases were late morphea and 13 cases were early morphea. And subtype of morphea clinically was 7 had plaque form morphea, 7 was generalized morphea, and 6 had linear. Systemic involvement in systemic scleroderma, 5 cases had associated lung involvement, and 3 had cardiac involvement, 2 had joint involvement, and 4 had GERD and oral ulcers. And subtype of systemic scleroderma clinically, 4 had diffuse systemic scleroderma, 8 had limited cutaneous systemic scleroderma, and 1 was VDOS, very early diagnosis of systemic scleroderma. And in my study, approximately 22.8 cases per 1 lakh population was the prevalence. And coming to discussion, female predominance in systemic scleroderma and mean age was consistent with the literature. And diabetes and hypothyroidism were the associated comorbidities found. According to a study by Hasan et al., elevated TSH can be found in 41.2% of morphea. And diabetes can cause scleroderma-like features and can be in association. So hyperpigmented lesions were more common in morphea, and hypopigmented lesions and digital ulcers, telangiectasias, and erythematous borders were found in systemic sclerosis, which is consistent with the findings in literature. And significant overlap was there in histopathological findings, which is also consistent with the literature. And SLE sclerodoma and Sjogren's sclerodoma are already having a well-established overlap syndromes, and porphyria cutanea tarda and generalized morphea can also occur together according to the literature. Morphea had mostly negative autoimmune serology, and 4 cases had positive autoimmune serology. According to a study by Delia et al., they said that 4 out of 6 cases which developed from morphea to systemic sclerodoma had positive autoimmune serology. Systemic involvement was also inconsistent with literature. The limitations of my study is that subcutaneous involvement could not be assessed in all the cases, and ANA profiling was not available for all the cases of morphea, and diabetes mellitus and hypothyroidism was observed in both the cases, but statistical analysis did not have a significant association between them. And the conclusion of my study is that to provide insight into differences and similarities between localized and systemic sclerodoma, it implies the importance of clinico-pathological correlation, and histological classification of morphea based on inflammation and degree of homogenization of collagen was done as early and late morphea. So this enhanced the understanding of scleroderma's clinical and pathological spectrum, aiding in more accurate diagnosis and management of this rare connective tissue disease. These are my references. Thank you.
Questions from the judges, please.
Hello. Yes, Dr. Swetha, you said that subcutaneous fat was included and not included. So was it important? Like,
Studies show that systemic sclerosis have more subcutaneous involvement, but in my study it was very less. It was because most of the biopsies were not deep enough, and we were not able to assess the involvement of subcutaneous.
so you suggest the biopsy with subcutaneous fat, or just like that is okay?
No, with the subcutaneous fat, we can tell the extent of scleroderma.
Scleroderma. Okay. Yes. Thank you.
How are the ANAs done in these patients? You said in the morphea you did not have the ANA profile, right?
So I'm not able to understand.
ANA.
ANA profiling, yes, sir. ANA global and subtyping of ANA was also done in certain cases, but it was not available for all the cases.
What was the initial screening done with? Which technique?
Initial screenings.
Of ANA?
ANA global was done, sir.
Okay.
Any cases which were associated with Crest syndrome?
Sir, Crest syndrome? No, sir.
What were the involvement of the lung and heart you got?
4 cases had associated interstitial lung disease involvement. There were nodules and interstitial lung disease were there. And cardiac involvement was seen in 3 cases.
How did it manifest, the cardiac involvement?
Because of the fibrosis, one of the patient had cardiomegaly. Exactly, I'm not sure.
Okay, thank you.
Yes, thank you, sir.
Thank you, Dr. Swadha. Next, Dr. Shatobisha Pal. It's okay, Shatobisha?
Yeah. Should I start?
Shall we start?
Yeah.
Go.
Good afternoon, everyone. I'll be presenting my paper on clinical laboratory profile of systemic lupus erythematosus patients. So SLE is a systemic autoimmune disease that leads to multi-organ dysfunction by the generation of autoantibodies against various autoantigens. Lupus nephritis is a severe manifestation of SLE with up to 50% of lupus nephritis cases progressing to end-stage renal disease. It is driven by immune complex-mediated inflammation in which autoantibodies against double-stranded DNA and preformed immune complexes deposit in glomeruli and cause inflammation. Increased levels of low-density granulocytes, which produces netosis, leads to systemic inflammation and immune tolerance. In addition, peripheral blood follicular T helper cells positively correlate with lupus activity and anti-DS DNA titers. Risk stratification of lupus nephritis patients based on peripheral blood immunophenotyping has shown promising results due to tailored treatment approach. So in this study, we aim to examine this association of immune subsets with severity of lupus nephritis and clinical and laboratory parameters. So the aims and objectives were to study the clinical manifestations, hematologic, immune subsets, and serologic parameters in SLE patients, to study the association between clinical, hematological, serological parameters with immune subsets in patients with SLE, and to study the association of the severity of lupus and immune subsets in SLE patients. It was a retrospective study of 4 years, from May 2021 to April 2024. All the cases with established diagnosis of SLE who have undergone autoimmune serology, renal biopsy, and immune subset evaluation were included in the study, while all the cases where clinical details or laboratory parameters were unavailable or pre-existing immune deficiency disorders and malignancy were excluded from the study. After IC approval at KMC Manipal, all the eligible cases were reviewed for clinical features, complete CBC, autoimmune serology, immune subsets, and renal biopsy findings. The data was analyzed using appropriate statistical tools. So coming to the results, table 1 shows the baseline study characteristics with their biological reference values. The bar diagram of gender distribution shows a female predominance of 89.3%. The most common clinical feature was pedal edema, and the majority of the patients had lupus nephritis class 4+5. This table 2 shows the association of clinical features and lab features with immune subsets. Among the clinical features, skin ulcers showed significant association, and among the lab features, hematocrit, platelets, and lymphocytes had significant association with the T cell subsets. Among the serological parameters, anti-cardiolipin antibodies showed significant association, and lupus nephritis class 4+5 also showed significant association. Table 4 and Table 5 had showed the correlation of clinical indicators with the immune subsets, where neutrophils showed a negative correlation with the immune subset, indicating an inverse relationship between the two variables. Moving on to discussion, in this study of 28 SLE patients, skin involvement was a significant clinical feature and had a significant correlation with T cell subsets, indicating an underlying immune dysregulation. Lower hematocrit levels and lymphopenia were associated with T cell subsets. The association of anti-cardiolipin antibodies suggested their potential role in SLE pathogenesis. All the lupus nephritis classes had significantly lower T cell counts, highlighting their role in inflammation. Although B cells are considered as key cells in SLE pathogenesis, this study did not show significant association with variation in B cell subsets. So to conclude, the study underscores the importance of immune profiling in SLE patients. Even a basic T, B, and NK cell profiling gives valuable information regarding the severity of lupus nephritis. Understanding the relationship between immune cell subsets and clinical manifestations can lead to better disease monitoring and targeted therapies. Further research is needed to validate these findings through larger multi-center prospective studies. This will help in establishing more robust correlations and improving treatment strategies for SLE. These were my references. Thank you.
Questions from the judges, please.
What kind of targeted therapy would you advise if you get one particular, say, CD8 immune subset? Suggested that targeted
Yes.
therapy was would be considered
Yes, sir.
after immune profiling. That is, my general question is, how will this immune profiling help the clinician?
So basically, the SLE can be, my study shows that there can be like the profile, T, B, and NK cell all help in the pathogenesis of SLE. So if there is a, in my study, there was association with the T cell subsets. So that's why a T cell targeted therapy is usually.
But you said T cells were low in your patients, right?
Sorry, sir?
T cells were low in your patients.
Yes, sir. The T cells were low in these patients.
So why would you target the T cells then? And there were total 28 cases.
Yes,
How many
sir.
patients did underwent their renal biopsy? I mean, how many patients had All 28?
Yes, yes, sir.
All 28 had
All the
any
28
titers.
patients.
Was there any correlation with the dsDNA titers and renal involvement? dsDNA? Did you do the dsDNA?
Yes, sir. It was done. Among them, only 89% showed positive dsDNA.
Was there a correlation between the degree
Yes,
of-
sir. Statistically, the correlation was done, but no significant
not
association could be found.
And you did not include the regulatory T cells in your flow, in the lymphocyte panel, because the regulatory cells are
No,
very
sir.
important. Even if your T cells are, you said, low,
Yes.
a lot of things would depend on the regulatory T cells. So that was
No,
not looked
no,
at.
sir. That was not included.
These are retrospective studies.
Yes, sir. It's a retrospective
So
study.
she had no scope of including that. I may miss, how many cases were kidney problems are there or kidney involvement was there among
Sir,
all of them?
28 patients.
All the patients?
Yes, sir. So, lupus nephritis.
No, you are studying the SLE patients in tertiary care hospital. So all the 28 cases had kidney.
Lupus, yes, sir. All the
What?
28 patients. So that's like that's why the sample size came so less, because it was based on convenient sampling.
Okay, thank you. Our next participant, Dr. Shomik Shah.
Good afternoon, everyone, and judges. So my topic is clinicopathological presentation of IgG4-related ophthalmic diseases. Is it rarity in incidence or rarity in diagnosis? Let's explore. So the IgG4-related diseases encompasses multi-organ fibroinflammatory condition with tumefactive lesion and characteristic histopathological features. Virtually any organ can be involved, but most commonly involved organs are pancreas, kidney, or orbital adnexal structures, salivary glands, and retroperitoneum. Pathological hallmark includes dense lymphoplasmacytic infiltrate with IgG4 positive plasma cells, steroidiform fibrosis, obliterative phlebitis, and a variable number of eosinophils. Pathology is very specific and looks similar in all the organs. Etiology remains unclear. It is thought to be related to genetic background, bacterial infection, molecular mimicry, or autoimmune diseases. Immune dysregulation has been hypothesized as the most probable mechanism, and now orbital and adnexal involvement is common, collectively referred to as IgG4-related ophthalmic diseases, with varying degree of clinical presentation, symptom, and disease severity. The lacrimal gland is most commonly involved, and we have the organ-specific criteria, and for orbital disease specifically, Goto et al. Developed the diagnostic criteria in 2015, which includes the radiological features. We will be giving 1 point for radiological features, and next thing is pathological finding, which includes 3 points. First, the classical histopathological examination finding, then the ratio of the IgG4 positive plasma cell to the IgG positive plasma cell, which would be greater than 40%, and the number of IgG4 positive plasma cell per high power field, which will be greater than 50. If out of 3, 2 are coming out to be positive, then we will be giving 1 point to that. And the last is serological finding, that is serum IgG4 level greater than 135 milligram per DL. Now I will be presenting 6 cases that we got in last 1 month, that is 1 year, from May 2023 to 2024. And I will try to classify them. First, the case 1, which is the definitive case of IgG4-related ophthalmic diseases, because it was following all the criteria. Now, coming to the case 2, it was following only the first and second criteria, so it would be a probable case of IgG4-related diseases. Case 3, case 4, case 5, and case 6, they were only having the radiological and serological finding, though histopathological histopathological classical finding was present, but it was not following the actual criteria, so we could not give point for that. It was all the 4 were possible IgG4-related diseases. Now coming to the case 4, it showed epithelioid granulomata, so we have to do a ZN stain to rule out TB. And in case of case 5, it was showing an inflammatory lesion. So how our study was different, basically we had a adolescent subject included in our study, and none of them actually showed allergic symptom. All obliterative phlebitis was not a constant finding, but fibrosis was a constant finding. And the aberrant finding was epithelioid granulomata with Langerhans giant cells. So coming to the discussion, histopathological features depend on the duration and stage of the disease process. The fact is not well documented in literature. If advanced fibrotic phase, IgG4 positive plasma cell can actually be low. Additionally, there are chances that the biopsy being taken from non-representative area or a sampling error. Hence, insufficient histopathological evidence does not essentially rule out the possibility. It can rather be a guide for further follow-up and workup, or just to rule out the mimics. In our study, 83% showed classical histopathology picture and 33% actually fulfilled the required pathological criteria. Our finding was supported by the fact that all the 6 patients responded to steroid therapy, and 33% actually relapsed after stopping the steroid therapy. Coming to the conclusion, IgG4 related diseases is heterogeneous both in terms of clinical presentation and histomorphology. Thus, high level of clinical suspicion, symptom related to other organ involvement, correlation with other laboratory finding, and exclusion of differential may actually help us in reaching the actual diagnosis. Ratio of IgG4 to IgG positive plasma cell may vary and cannot be relied upon. It can be of help in case of ruling out a differential, like IgG4 positive plasma cell can actually be raised in multoma. So level of IgG4 in isolation is of limited diagnostic purpose. It can have role in disease monitoring and progression. It is responsive to steroid, but relapse is common, but it is not considered to be diagnostic criteria. Here are my differences. Thank you.
Thank you. You said there is an enlargement of lacrimal gland.
Yes, ma'am.
So is there any cutoff point that this much enlargement or this much involvement?
No, ma'am. Actually, the thing is, they were saying it has to be a dacrocystitis, and or otherwise a tumor-like lesion in a radiological picture. It can be even infiltration of the fat that can come out to be a tumor-like lesion in the MRI picture or radiologically. So there was no cutoff of that. So a patient presenting with a dacrocystitis-like features and radiological finding correlating, so it's a positive finding for that.
You found granulomas in one case.
Yes, sir.
And did you get AFB?
Sir, ZN was done. TB was ruled out, and later TB-PCR was done. It was a negative.
It was negative.
Negative.
So what was the cause of
actually,
the
sir, while I was searching, while I was doing this, I searched a paper in 2022. There is a paper which actually cited that there can be Langerhans granulomata in IgG4-related disease. That's why I'm telling. So we are probably coming short of diagnosing is. Basically, we have to think beyond what we have at the moment, like classical picture. It can be heterogeneous in clinical also and histomorphologically, both. Thank you.
Thank you, sir. Dr. Anu Singh.
Good afternoon, everyone. Today I'm going to present my original study, Frequency of Anti-Neutrophilic Cytoplasmic Antibodies in SLE and its relevance with clinical manifestations. So as we all know, SLE is an inflammatory multisystem autoimmune disease with protein clinical and laboratory manifestations and a variable course and prognosis. It manifests with various systemic involvement like dermatological, musculoskeletal, hematological, renal, cerebral, and gastrointestinal involvement. So prevalence is approximately 2 to 140 per 1 lakh population worldwide. Incidence is 1 to 10 in 1 lakh population worldwide. Whereas in India, it is approximately 3 per 1 lakh population. And the high population which is at highest risk is women in their reproductive years. So female to male ratio is approximately 10:1, and there is a variation in rate and races. That is most common in blacks and Hispanic population, also common among Asian populations. So the most common autoantibodies associated with with SLE is ANA, anti-dsDNA, anti-Smith. Anti-dsDNA and anti-Smith being highly specific, whereas anti-RNP, SSA and SSA-B is not as specific as these, and they have certain clinical associations with them. So anti-dsDNA and anti-Smith have an important role in pathogenesis and diagnosis of SLE. We studied here ANCA. So ANCA is formed against cytoplasmic antigen in azorophilic granules of neutrophils and lysozymes of monocytes. Proteinase, there are two types of ANCA, proteinase 3 ANCA and MPO ANCA, which is common in granulomatous with polyangiitis, and MPO ANCA is common in microscopic polyangiitis and eosinophilic granulomatosis. So besides small vasculitis, ANCA is also detected in SLE. So disease activity and flares is very important in this, which is indicated by new evidence of complement consumption, rising anti-dsDNA titers, increasing ESR, and new lymphopenia in certain studies. So diagnosis of SLE is made on the basis of 2019 EULAR ACR criteria. So in our study, we used 2019 EULAR ACR criteria for diagnosis of SLE. So the background, we had to study the role of ANCA, which is association with clinical manifestations is not completely understood, and prevalence data is limited. Aim of the study was to measure the prevalence of ANCA in SLE patient and study its association with clinical manifestations of SLE. It was a cross-sectional study of 18 months conducted in the year 2022-23 in our institute. 92 SLE patients were included in our study, and demographic, clinical, and laboratory data was studied. Patients on immunosuppressants and SLE ANCA-associated vasculitis overlap syndrome was excluded from the study. So we measured ANA by indirect immunofluorescence, whereas serum levels of MPA proteinase 3 ANCA was measured, and anti-DSNA and ENA profiling was done by immunoglot, and serum complement levels were also measured along with hematological parameters. And statistically, we apply unpaired t-stat and chi-square test. So in the results, the mean age of presentation was approx 31 years, and ANCA positive group younger population was more involved, and female obviously were most commonly affected, and frequency involvement of male was more common in ANCA positive patient. Among total 92 SLE patients, 19 patients were ANCA positive, 10 positive for proteinase 3 ANCA, and 7 positive for MPO ANCA, and 2 both dual positive for MPO and PR3 ANCA. The most common clinical manifestation in our study was arthritis, followed by alopecia and fever. In nephritis, we found a statistical significance that ANCA positive patients were significantly higher than the ANCA negative group. And reduced complement levels, WBC count, lymphocyte count, and platelet was observed more in ANCA positive patients. However, it was not statistically significant. Then there were certain autoantibodies which were associated, but they were obviously more common in ANCA positive patient, but this statistical significance could not be established. So to summarize, anti-DNA level was the most commonly elevated in the SLE, followed by H3 SSA. Anti-RNP antibody was slightly higher in our study compared to the previous study. Then nephritis was significantly more common in ANCA positive SLE patients, and fever, malar rash, alopecia, photophobia, nephritis was more frequent in ANCA positive SLE patients, but it was not statistically significant. Similarly, other levels were reduced, but we could not establish any statistical significance. Coming to discussion, most of the studies, the most common clinical manifestation of arthritis, then alopecia and nephritis. In our study, ANCA positivity was more common in 20% comparative to other studies, whereas in few studies, proteinase 3 ANCA were more common, and few studies, MPO ANCA was more common. And ANCA association was found in our study with nephritis, whereas in other studies, serositis and renal involvement and myocarditis and neurological abnormalities could be established. So variation in ANCA was because of demographic variation, population ethnicity, and effect of immunosuppression was also there. and above factor could be excluded from our studies. An earlier study found an association with reduction in complement level, where there was nothing like that in our study, and no association with hematological parameters. So, along with the sub-antibodies, there was no significant observation, and there was in one study, there was a positivity rate of anti-DSD and anti-Smith antibody, significantly higher ANCA positive patients, whereas it was showed a positive relation on ANCA level with disease activity only. Coming to conclusion, ANCA in SLE is not uncommon, and present study, it showed that renal involvement is more frequent in ANCA positive SLE patient, and ANCA is not yet sufficiently analyzed and potential diagnostic or prognostic marker, and measurement of ANCA is helpful to predict or diagnose renal involvement in SLE patients. These were of the limitations of my studies. There were less sample size, and it was not sufficient to confirm or rule out association, and disease activity could not be followed up. These are my differences. Thank you.
In the patients with nephritis, were any renal biopsies done, or is it just clinically nephritis?
No, sir, renal biopsy was done.
So what were the lesions that were being?
Sir, most common were mesangial-proliferative and diffuse lesions were most common among these nephritic patients.
You should have included the data in your presentation. That is an important part.
Sir, I didn't include that in my data, which is the most common subtype.
Yeah, that is the only statistically significant finding, as he's saying. That is
So,
the most important message in your.
That is, yeah. All the others are statistically insignificant. So you should have included that data
Yes, sir.
particularly. So what would be your message to the clinician? Should they do ANCA or should they not do ANCA?
Sir, we don't have sufficient study, but we can definitely establish an association between ANCA and disease severity and activity of SLE and renal manifestations. But unfortunately, there are not so many significant studies. So we can include ANCA in, because sir, we are currently doing ANCA routinely in all the SLE confirmed cases.
So that could replace biopsy, renal biopsy?
Definitely not.
So anyway, if you have to do renal biopsy, that would give you the best prognostic significance, isn't it?
Yes, sir. Yes, sir.
So you're just adding on to the cost of for the patient without any extra benefit.
So maybe with ANCA positive, we can change some treatment modality. We can add certain drugs if it is ANCA positive. I guess we did this research in very initial stage. We can add something to that.
In the discussion, have you mentioned your finding is that on less than 20%, probably if 19% only are ANCA positive
Yes,
in your
sir.
study?
20%, yeah. Among the 92 patients,
In the
approx
discussion,
20%.
what are the other pictures? What are the other studies in Indian patients?
Sir, ANCA 4 to 5 studies have been done.
No, that's right. Have you, in the discussion, have you mentioned that these agrees or disagrees with the other important findings? Is there, what is the prevalence? So you are studying the prevalence. So what is the prevalence in other studies?
Sir, it was approximately ranging from 16% to 40% prevalence of ANCA in other studies. So, but that depends on other factors also. They didn't apply the exclusion criteria of
You have applied
removing the
exclusion
immunosuppressants.
criteria of those who are on immunosuppressive?
Yes, sir. And SLE, ANCA-associated vasculitis overlap syndrome, that we excluded from our study.
So immunosuppressive not growing. So what course of treatment getting you in your patients?
Sir, because we included the patient with the initial diagnosis, that is why immunosuppressant patients were not included. We took the specific history. Most of the patients which come to our center are with the initial diagnosis.
Initial then, okay.
Yes, sir.
Okay, thank you.
Thank you, sir.
Dr. Orchita Dash. Start, please.
Welcome to everyone for the presentation. The paper I am going to be present is entitled as Study of Clinicopathological and Direct Immunofluorescence Findings of Crescentic Lesion Associated Different Classes of Adult Lupus Nephritis, Its Significance and Outcome from a Tertiary Care Hospital. Crescentic glomerulonephritis is a pathology condition characterized by extracapillary proliferation in more than 50% glomeruli. It occurs in background of various renal diseases, among them lupus nephritis is the commonest. Disease having a bimodal age distribution with equal male-female ratio. Clinical features ranging from the fever, arthralgia, hematuria up to the multisystemic involvement. Following disruption of the glomerular capillary wall due to injury, the parietal epithelial cells, the fibroblast, the coagulation protein, macrophage T cell crossing the capillary wall into the Bowman space and forming the crescents. Immunological mechanism playing an important role in formation of the crescents, macrophage contributing by secreting TNF-alpha, nitric oxide, neutrophil by reactive oxygen species and myeloperoxidase enzyme, B cells by producing autoantibodies, T helper 1 cell by producing interferon gamma, and T helper 17 cell by producing interleukin 17A. This is the, according to the latest literature, human amniotic epithelial cell prevent the glomerular damage following this mechanism. We included 51 biopsy-proven lupus nephritis cases diagnosed in our hospital from January 2023 to June 2023. The renal biopsy is examined by both histopathological and direct immunofluorescence examination. For histopathological, we use 4 stain. For DIF, we use 7 panel of antibodies. Picture showing the method of sample collection. This is the ISN RPS classification according to which we diagnose our lupus nephritis cases. Now I am showing you few photo micrograph of our representative cases. The low power view showing the back-to-back tubules and the glomerulus, all the glomerulus having crescents. High power visualize the crescents more better. This is the class 4 lupus having mesangial as well as endocapillary proliferation with lobular accentuation and neutrophilic infiltration. MT showing the appreciable wear loop, the silver showing the double contouring. This is the features of crescent and lupus in the same focus. DIF showing the full house positivity with peripheral capillary wall deposition. Now coming to the result analysis part, this is the baseline characteristics of the whole study cohort. Average age of our study cohort is 29 years, anti-dsDNA positivity 45% and the ANA positivity is 60%. Most common clinical entity is SLE, second most common is arthritis. Now we divided our total study cohort into 3 categories based on the percentage of total crescent formation. Mild category less than 25% crescent, moderate category 25 to 50% crescent and severe category more than 50% crescent. This is the comparison table between that 3 categories. The arthritis and the skin lesion is maximum in moderate category. The biochemical, according to the biochemical parameter, anti-dsDNA positivity and the NA positivity also highest in the moderate category. Now comparing according to the histopathological parameter, the endocapillary hypercellularity and the segmental sclerosis are highest in the mild category. The cellular crescent is highest in moderate category and the fibrous crescent, fibrocellular crescent and fibrinoid necrosis in the severe category. Interstitial inflammation in the moderate category, interstitial fibrosis also in moderate category, arteriosclerosis in mild category, IFTA percent is in severe category and the NIH activity score highest in the moderate category. But according to the class, in the all 3 category, the most commonest class is class 4A by C. This is the statistical significance of our studied parameter. Now we compare our study with associated other studies. According to the mean age and the male-female ratio corroborate with the associated other studies, but regarding most common presentation, we have found the arthritis and hypertension as most common presentation. But Kai F et al. Study and the Linus et al. Study have found proteinuria as most common presentation. Regarding poor prognostic factor, Chen et al. Study have found the activity chronicity index as the prognostic factor, but all other associated studies have found the crescent and type of crescent as poor prognostic factor. And regarding the class, lupus nephritis class 4 or other proliferative class, all the studies have found the most common diagnostic point. We conclude our study, histopathological and direct immunofluorescence examination is always gold standard for determination of class, activity and chronicity score. Lupus nephritis patients with a moderate number of histological crescent formation have high NIH activity score. Number of glomerular tuft affected by fibrocellular and fibrous crescent formation is important predictor predictor of prognosis than determination of lupus classes. More number of tuft affected by fibrocellular and fibrous crescent formation having more chance of progression to CKD. Isolated feature of greater number of crescent is not always associated with a poor prognosis. Crescent formation may be seen in both first presentation or during the course of disease process or therapy. In inadequately treated patients, prognosis becomes frequently unfavorable and may develop acute renal failure. Early diagnostic screening and subsequent therapeutic intervention always lead to better outcome and higher chance of remission. These are my references. Thank you everyone for your patience here.
Sir, questions?
The aim of your study was to look at crescents in different classes of. So you saw crescents in all classes of lupus nephritis?
Yes, sir. I have seen crescents in all classes, but percentage of crescent have differed in all classes, and type of crescent also differed. Fibrocellular, fibrous, and cellular crescent. All cases have crescent. Sorry, sir.
Sir, please use the mic, sir.
Please show the table where you have highlighted it.
Show the table where you have highlighted it.
Because your cardios are finding out crescents in different classes.
Please put her PPT on once again.
Sir, I cannot find my PPT.
Wait. They will put it on. They will put it on. Wait.
Put it on, no problem. Relax.
Relax.
This pie chart I have made from that